Hi, everyone. Welcome to another issue or another edition of 10 Minutes with JPIDS. I'm your editor-in-chief, Ravi Jhaveri, and I'm really excited to be joined by two of my colleagues from CHOP, Katie Chiotos and Jeff Gerber. Uh, he's not actually a Zoom user. That's just didn't change your name there. Um,
I'll work
but
on
we're
it.
really excited about the paper you published with us discussing off-target effects of your stewardship efforts and wanted to dive in a little bit more. So, frequent listeners of the podcast know that I start each episode with the same question. So, Jeff is our first repeat guest on the podcast. So, Jeff, I'll make you a medal and send it to you just to mark the occasion.
All
But,
right.
Katie, we'll focus on you. So, if you could share. I always start out with the fact that I feel like I'm a superhero nerd, and every superhero has their origin story. So, if you could share with us your origin story, knowing that you are cross-trained in ID and critical care. So you have a unique origin story, and I'm sure people would love to hear it.
Yeah, sure. So I got really interested in ID during my second year medical school time when we had a microbiology lecture. I found the people who taught that lecture to be like so smart and insightful, and they knew all of these things about bugs and drugs, and they knew exactly how to treat them. And I just thought that was so cool compared to so many of the other topics that we were learning about. They were like curing things, and they knew why they were curing them. So that was really, really neat. So my first rotation of my fourth year of medical school and actually of my intern year of residency was an ID elective. And I just really enjoyed the time and found everyone I worked with just to be so smart and knowledgeable and such experts in their area. And I still feel as though we always see the most interesting patients in the hospital, both inside and outside of the ICU. And I think that's still true when I compare my ID time with my critical care time, that I just always feel really excited about the patients that we've seen on the ID service. I found myself in this kind of dual training land because I also really liked the PICU and really liked the physiology of the patients I was taking care of there. And I really just like being the primary team and the person who's sort of
Mhm.
the coordinator of the care and the final decision maker. And I really found that something that I would find really hard to give up if I was solely doing infectious diseases. But there's actually so much overlap in the way intensivists think and the way ID doctors think that I think they really complement each other really nicely. And so, it's been really great to be able to practice both here at CHOP.
Nice. Yeah, that was a very diplomatic answer, but I appreciate that. Your secret is safe in terms of the ID part of your case is being more interesting. We'll amongst our podcast crew, we'll keep that a secret.
We
Um,
also get to see the interesting critically ill patients, which is,
yes, yeah,
the
for
best
sure.
kind of interesting patients.
For sure. So, just for our readers, thinking about this particular paper and this particular project actually is an offshoot of a prior project you were doing. So, could you walk us through the foundational work that you did that led you to then ask the question that you asked in this particular paper?
Yeah, Jeff, I think this really started with work you did a while ago. I don't know if you want to start by talking about where you started, and then I can pick up and talk through some of the more recent stuff.
Yeah, I'll go briefly. I mean, I guess maybe it depends on how far back you want to go. I'm pretty old, and we had done so a long time ago, did some work trying to influence antibiotic prescribing in the outpatient setting for common respiratory infections, and built on some prior behavioral work to say, if people see how they're being scored and get some feedback, sometimes that works, and we had some success giving, auditing, prescribing, and providing feedback reports to outpatient docs for some of the some common infections. And and so that's, maybe some of the basis. And we were able to, Katie and I were able to partner with CDC, who's been a great partner. I want to call it CDC because
Hmm.
of how much credit they should be getting
Yeah.
these days. And they're just incredible partners across the board, but particularly with antimicrobial stewardship work. And they, wanted to partner on some ways to make some of this stewardship work a little bit more automated, a little bit more streamlined. And I think maybe that's where I can kick it over to Katie for the background project that was the previously published work.
Yeah, so we really built upon work that Jeff had started and tried very hard to develop like an electronic definition, both of community-acquired pneumonia as well as appropriate antibiotic use for community-acquired pneumonia among hospitalized children. So appropriate initial choice of antibiotics and appropriate total duration of antibiotics, considering both inpatient and outpatient antibiotic use. And so in the original study, we sort of took that definition, which had been extensively validated, and partnered with our hospital medicine colleagues to develop feedback reports that kind of summarized their adherence to recommended first-line antibiotic choices and antibiotic durations for hospitalized kids who were being treated for community-acquired pneumonia. Part of the challenge is that in order for those indicators of appropriate antibiotic use to be, really reliable, we ended up having to exclude quite a few kids because the initial treatment choices and the antibiotic durations can be more ambiguous in certain populations. And we really wanted these feedback reports just to have maximum credibility amongst our clinicians. And so the original study was quite successful in improving clinician performance. We were originally quite often giving the right initial antibiotic choice, but we're treating these kids very often for way too long. And so we were able to significantly improve performance on that front through this feedback report-based intervention to our hospital medicine colleagues. So that was kind of the original study with which this one is an offshoot.
And so thanks for that summary. So as you were studying sort of these off-target effects, or what I was calling sort of collateral benefit, what were some of the unique challenges in trying to define sort of this effect?
Yeah, I think thinking about this population in general, it is kind of tricky, but we felt like it was just so important, at our hospital, and I'm sure at Lurie and other major children's hospitals, healthy kids are some of our patients, but so many of them that utilize our healthcare system over and over are the ones who have medical problems or on immunosuppressive medications and, things along those lines. So we thought it was just so important to try to capture that patient in some kind of way, particularly since they were excluded from of those feedback reports. I think a couple of the challenges on that front was really trying to be selective about who we were talking about, particularly given that there's not a lot of clinical data to inform optimal antibiotic choice in that population. They're excluded from national guidelines. They've not been included in randomized trials, and even observational data is quite limited in those kids. So I want to be very clear that our study wasn't an efficacy study around whether or not it's right or wrong to give patients amoxicillin or ampicillin as first line antibiotics or to treat them for 5 days. Really, what we were trying to understand is this stewardship tool impacting kids more broadly than the population it was intended for? And so how does this impact clinician behavior? So it's really kind of to understand mechanism. I will say that we didn't see any safety signals in our small population, but our study really wasn't designed for that particular question. And so I think one of the biggest challenges, just to name it a little bit more specifically, is the lack of data to inform this. And that's really why that wasn't the focus of the primary study here and was a sort of a secondary study.
Anything you want to add, Jeff?
Yeah, I mean, just what Katie said, I guess one more thing is that since it was exploratory analysis, we hadn't been initially powered for this. So,
Yeah.
we're working with smaller numbers, but I think,
Yeah.
that can be okay as long as you lay it out there. But just like Katie said, I think, reiterating medical complexity is such a large term and there's a lot of variation within that. But I feel like this was hopefully a good first step.
Yeah. So in sort of alluding to this as the first step, what do you think are the subsequent steps? Because my guess is there's still, as you said, a lot of room for future study. So where are you guys going from here after sort of defining this collateral benefit? What's next?
Yeah, so I think a couple of things. I mean, of course, feedback reports are a really commonly utilized stewardship strategy. And so I think one thing that investigators, and I know we'll think about this in the future, is the balance between who do you include in the feedback report and really what are you trying to accomplish here? That is to say, do we really need to give feedback on every single patient, or are we really trying to get clinicians to buy into a concept? And I'm increasingly coming around to the idea that it's really the latter, and that at least I'll think about feedback reports a little bit differently. And I think the more work we can do to understand sort of what works and why, with this particular stewardship strategy and all of them will be really important to kind of keep the field moving forward and start to develop those sort of evidence-based practices within stewardship, akin to where IP&C was many years ago before we had all these evidence-based bundles and things along those lines. So I think building the evidence base around feedback reports and what the best way to do that is a really important next step. I think related to that is building the evidence based around what antibiotics are best for kids who are medically complex, critically ill, immunocompromised. And I think there have been more work done in that group over the years, although I think the data really are limited in those populations. So I think it's a charge to all of us to kind of include those patients in thinking about ways to study them most robustly. I can share that Jeff and myself mentored one of our ID fellows who recently graduated and presented some work at ID Week. So a big shout out to Mahi Ekambaram, who did work comparing initial antibiotic choice of broad spectrum antibiotics versus amoxicillin or ampicillin in kids coming to our hospital with community acquired pneumonia, and did a lot of really sophisticated analyses to really try to balance, the baseline differences in those populations using a target trial emulation framework and propensity scores, and really tried to get at this confounding by indication as best as we possibly could, and really did not see a difference between initial amoxicillin or ampicillin versus broader spectrum agents. So look for that paper to come out in the coming months, and we're really excited about those results and think it's a good contribution to a limited evidence base. So as I said, hopefully we'll be able to keep building that evidence base moving forward.
So if I could just follow up, since I'm not naturally a steward, when you say construct, are you sort of saying that in general, rather than looking at a specific indication for drug and duration, you're really sort of saying what we sort of all know, which is that amongst our groups, there tends to be the people who tend to treat for shorter periods of time versus those who treat longer, and that across indications, those patterns tend to hold. Are you saying something different?
I guess I was saying that we should, with the feedback reports, that we tend to lean into where we have the most evidence in terms of giving that feedback to people. Clinicians, what they do with that evidence and how they apply it to populations maybe outside to the population that was included in that trial, I think can be variable. And so I guess the point I was trying to make is that with our feedback reports, we are getting people to buy into an evidence-based practice that may have applications beyond the original population that was in the feedback report, that was in the trial.
I got it. Okay.
And in doing so, we, offer, a broader population of children, the evidence-based kind of treatment approach, narrow spectrum, shorter duration of antimicrobials.
Got it. Okay.
Yeah, thanks for clarifying.
Yeah, no problem. Sorry, I was confused about that. So as we sort of talk about this project, maybe I'd just leave this open to sort of say what other thoughts or any advice you want to share to any of our listeners, either trainees, junior faculty, as they embark on projects that are similar thematically or methodologically.
I guess I would just reiterate to think about, the kid in front of you and the challenges that you face when you're caring for patients. I think that's what kind of drove us to look at this particular question, because we heard from our hospitalist colleagues and in our own practice, a lot of the challenging cases aren't the healthy kids. They're the kids who have some complexity. So I think don't forget the kids that you're caring for when you're thinking about these research questions. And then I think the most interesting question sometimes of a project isn't the one you started with, but maybe one that comes from the data and comes from kind of thinking about the clinical problem, over time. So I think keeping an open mind to offshoot projects and things that might not have been your original goal can be really meaningful.
Yeah, I'll aim at that for sure.
Completely agree. That's the fun of doing research. For every project you do, a few come out of it. And I would just completely reiterate what Katie said, like, be as inclusive as possible. Everybody loves the randomized trial, right? But they're long, they're expensive, and you typically end up, not being as generalizable. And, we've now got big electronic health records, lots of administrative data. It's a challenge, but it's a fun challenge. And with advanced causal methods, if you partner with the right people, you can really do studies that can be as inclusive as possible. And maybe some of the analyses are a little bit stratified and a little bit small. But hopefully we can continue to do that to extrapolate so we're not just treating, 20% of the patients with
Right.
evidence.
Right. Totally agree. All right. Well, Katie and Jeff, thanks so much for joining us. Thanks for publishing with JPIDS, and we look forward to more of this work in the future. So I just want to say thanks to our listeners, and we'll see you with the next episode.
Thanks so much.
Thank you.